All right, well, let's talk about test taking. I'm going to say the same thing I said before, is if you are somebody who always does great on tests and you're just here visiting your daughter in graduate school, there's a mall that's like right over there. It's really cool to walk around in, and you probably don't need this. If you always do well on tests and you know all the sort of general strategies and you're fine, that's good. If you say, I haven't taken this test for a while, I really want to know what to study, I want some details on what to think about, I want to know how to think like an examiner, I want to know what materials to study in both sort of theoretical and actual aspects, then hang around, and then I'm going to stay around as late as people want to talk to me one at a time about sort of helping you with individual stuff. I also am happy to give you my email, and I can work with you over a period of time to develop a study program. It's easier if you have your last board scores, but I can do it in general based on your practice. It's like if you've done nothing but insurance work for the last 30 years, there's a little bit more catching up to do than if you're practicing mainstream family medicine. But lots of us are specializing into sports medicine. Somebody told me they do lots of endoscopies and things, and so one of my passions is I don't do much other volunteer work because I'm like working all the time, but I really have a passion to make sure everybody who's practicing active family medicine has the best chance of keeping their board certification. So I'm happy to help you any way I can. So this was like the coolest thing I ever saw. My first trip to China, I went out of Seattle, and this is Siberia. And you go for hundreds of miles without even seeing a yak. It's just like absolutely nothing. So I'd always like seen it on the map, and I went, oh, that's interesting. In person, it's like, whoa. So lecture modules, we're going to talk about the ABFM certification exam, talk about the exam strategies, exam day and prep, and some personal care stuff. So certification exam, the ABFM did a study where they checked the performance of the ABFM exam, and they tried to determine if it relates to test-taking skills or to knowledge alone. And what they found is they took 4 people who were really good at taking tests. So one of my friends, Bob Cooney, when I was in medical school, he was a graduate student, and he went and took the weed examiner's test because he could get $30 an hour doing that. He didn't know anything about weeds, and he didn't study for the test. He was just a good test taker. And the test, he could just guess the answers by the structure of the questions. And so he got a really good summer job. That was back when $30 an hour was a lot, and it did well for him. So this board thought, I wonder if this exam is cued, or if people who don't have medical knowledge could just guess it from the way that the questions are structured. So they took 4 non-physicians who performed better in terms of they didn't perform any better than chance alone, just guessing. None of them performed well enough to fall within 8 standard deviations of passing. So that's pretty low scores, and that means that the test is pretty much about knowledge. Their performance was far below that of almost all physicians who completed the exam. Given that the non-physicians relied heavily on the identifying cues and phrasing of the items and the manner in which response options were presented, results affirm the notion that the ABFM certification exam is not primarily a measure of generic test-taking ability, but measures information critical to the estimation of a family physician's knowledge sufficient for certification. Item analysis confirmed that items were well written, provide minimal cueing, and required medical knowledge to answer correctly. So that's true. But does that mean that some of those things I taught you about cueing might not make a 1% difference? It's like, no. And 1% difference can make the difference between passing and failing, because sometimes the 2 to 4 questions can put you up 20 points or 30 points. About the exam, so who writes these things? Crazy people like me. And so they take people who've scored really well, usually from academic institutions, and have super good scores, and say, hey, do you want to be an item writer? And a lot of people go, sure. So the ABFM certification and recertification exams use only multiple choice stuff. There's no essay or anything else like that. It's one best answer. You have roughly 1 minute per question. The age group stratification, 65 to 70% of the test questions are adult-based, 10 to 15% geriatric, 5 to 10 peds, 5 to 10 adolescents. So what does that mean? We use the Willie Sutton principle. You guys all know Willie Sutton? Right. So why do you rob banks? That's where the money is. Why do you study adult diseases for the family medicine exam? That's where most of the questions are. So general principles, childhood growth and development, adolescence, sexuality, separation, autonomy, puberty, senescence, normal physical mental changes with aging, medical ethics, jurisprudence, biostatistics, epidemiology, and patient safety, probably around 10% of the exam. Organ systems, closer to 90%. So let's hear it for organ systems. So health maintenance, about 15 to 20%. Promoting health promotion, understanding disease mechanisms, 5 to 10%. but 55 to 65% of the exam is diagnosis and treatment. So adult diagnosis and treatment is about 60% of the exam. Read every response option carefully. Strategies. Read the question. Anticipate the answer as you read the question. Don't get bogged down in superfluous information in the stem. Eliminate answers that are clearly wrong. When in doubt, the answer with the most information is often right, maybe. More so if it feels crowded, data-ish, or explanation-filled. It's like, oh, they were really trying to make it precise rather than it's just long-winded. Only after reading all the options should you suggest the option you think is correct. So, which of the following patients is most likely to have a decubitus ulcer? An elderly man in a nursing home. Yep, that's it. Check. Okay, we're done. Next question. A patient who suffered severe head injury and has been unconscious for 24 hours. Guy's not moving at all. That's terrible. He's going to get a decubitus ulcer. Yeah, but not in 24 hours. A demented individual is constantly wandering the halls. There's a lot of things can happen to a demented individual who's constantly wandering the halls. A decubitus ulcer is not one of them. A person with severe respiratory disorder who's been bedridden for months. Bing, 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 bing. So what the answer is, don't just go to something that has part of the answer and read the whole thing and see what's the most correct. You want the most true answer, not just something true. That's why you want to read the whole question carefully with an open mind. Then read and think about all the answers. There are two types of questions that the board forbids and hence API doesn't use, which is all of the following except, or which of the following is not. And the reason they do that is those tests don't discriminate. You know, even super smart people just read them wrong enough at the time that it doesn't tell you who knows the knowledge, it tells you who happened to read the question right. And so would it be good to have doctors reading everything right to make the right decision? Sure. But when you're trying to discriminate medical knowledge, that doesn't work. And then questions with fewer than 5 answer choices don't discriminate well. They can't tell the top people from the bottom people, so you always should have 5 answer choices. So the only time there'd be 4 is if like one of them had to be scratched at the last minute, but they would more likely find somebody to make one up. If you're unsure, guess. There's no penalty for guessing. They don't subtract. If 2 answers are exactly opposite, one or the other is likely correct. Not always, it just increases the chance. We talked about who writes them, so that's folks that get invited to, and then what happens to them? They first go to the ABFM staff that edits them, makes them grammatically correct, and then checks the references and makes sure they're right. Then they go to a group called the Angoff Committee that breaks up into different subgroups so that they aren't influencing each other, and then they score them and they say, what percentage of practicing family docs should know this? Is this question worded right? Is it fair? Is the reference correct? And then they see if the two groups agree with each other enough of the time to do that. And then they say, well, should this be only in the module exam or could this be in the general exam? So flag any items that you leave blank as you progress through the test. So I generally think it's better to answer a question and then flag it electronically than to leave it blank. Because one of the things you can do is you could forget to go back and get it. So that way you at least get the guessing percentage. Computer-based flag feature enables you to quickly review unanswered questions later as the test progresses. I used to think the computer exams were terrible. I always wanted written ones, but they're actually getting better, or maybe I'm getting better at it. It's hard to tell. The first thoughtful answer an examinee makes is usually the best answer. So I know this quite well from being the clerkship director in family medicine for a decade because I gave pen and paper exams and I could see who crossed out answers and put in other things. And it's probably like 3-to-1 ratio of changing right answers to wrong as opposed to changing wrong answers to right. So if you think, yeah, that's it, unless you get some really good piece of data like, oh, this is because of that, and I'm sure of it, rather than, well, no, maybe it's this, maybe it's that, 3-to-1. In other words, changing answers usually doesn't increase your score. Don't get tricked by partially correct answers. You need to pick the best answer. Qualifiers such as never, always, and every are typically false. Begin with the end in mind. Which drug is the most likely cause of rhabdomyolysis in this group? Atorvastatin. It's statins. Great, we're done. Oops, simvastatin, higher risk. Remember that they changed the maximum dose from 80 milligrams down to 40 milligrams because it causes higher risk. Gemfibrozole, fibrates, when combined with statins do it, but by themselves don't. Clofibrate, another nasty fibrate, but rhabdomyolysis is not its big thing. And concentrated fish oil capsules, if anything, would probably make it less likely. So you want the most correct answer, so read all the choices. If you just look for a statin, you found atorvastatin and moved on, there would be a lurking simvastatin as a correct answer that would haunt you in the end. Do not try to outguess the item writers. Rely simply on your knowledge to respond to that. So one of my friends who's a very shoot-from-the-hip type of guy, he would say, what would I do? It's like, nothing. And so you think, well, that isn't going to work. So he'd say, well, what would Bob do? So it's like, oh, yeah. So somebody who's kind of compulsive, data-driven, but slightly cheap. And so, you don't just want to do every test to be compulsive, but you want to think about most things. So try to find that balance. Think about what good medical practice is. Think what most of your partners do. 24-year-old, 2 days postpartum with severe headache and double vision, equivocal papilledema. What test should they get? CT of the head, lumbar puncture, CT angio of the neck vessels, MRV, observation, no testing. Okay, so it would be debatable. What this person should probably have is an MRV, and that's not really a family medicine question that much because they're likely to have a dural sinus thrombosis, and MRV is better than MRA. CT would be okay, but it's not perfect. You don't want to do an LP until you've done an imaging study, and there's no great reason to do an angio. But this one's just to teach you that sometimes observation and no testing is a good choice. When they're saying, oh, should you spend a bunch of money on this? Should you get a CAT scan or whatever? It's like, a lot of times it's like you've had a stable migraine for 10 years, they're having a couple more, but they've had a lot of stress. Should you get a CAT scan? It's like, no. And so the times when the answer of observation is almost always wrong is during a time when there's serious stuff going on. So like a guy who runs a marathon and has severe chest pain, you should say, oh yeah, he's probably fine, don't worry about it. No. And somebody who's in the postpartum period is in a hypercoagulable state. So they get all sorts of immune phenomenon, all sorts of vascular shifts, all sorts of eclampsia, preeclampsia, posteclampsia, related HELP syndromes and liver stuff, and they also get a lot of clotting related things, and so they could have a venous clot in their brain. So the point of this was not to differentiate that you need the MRV as opposed to a CT. The point is that there are times and settings when observation might make sense, but during a super high risk critical period when all sorts of serious complications happen, you want to be cheap but not stupid. So consider the worst diagnosis and liability risk. So CT, okay for emergency bleed, but then you want to get the MRV. Don't do a lumbar puncture until you've ruled out herniation, and still it's not indicated because you're mostly looking for clot. CT angio, it might be helpful, but it's not as good as an MRV, which looks at venous stuff. And then the observation. So there have to be better clues if they want you to do nothing. It has to smell like, oh, there's nothing really going on here. I might kind of do that if I had to, but do nothing is a bad choice if it's a high risk with high risk and the person has focal symptoms. So strategies, reading the response options first and then finding the correct answer in the preceding material is not recommended. So I've counseled lots of our residents, and one of the other jobs I had at the medical school was to counsel people who were failing all their board exams and flunking out of their clerkships. And so some people got in because they shouldn't have gotten in, but they were in a special group. They said, oh, okay, you can come to medical school. And they went, this isn't really working out. But most of the people I counseled went away and did an MD, PhD, or they said, oh, I'm going to get a law degree. And then they came back and they didn't remember medicine. It's like, okay, you're going to have to get you back in the mode here, folks. So always ensure that you have answered all the items prior to ending the exam. If you leave 20 blank and there are 5 answer choices, the random would give you 20% or 4 more questions right. That could be 30 or 40 points and make the difference between a 390 and a 350. And so you really want to make sure at those margins that just a few extra questions will help you. So trust your office practice instincts. I had somebody who was taking the in-training exam over and over again and flunking it, and I said, just see what you do in clinic, what your partners do in clinic, what the faculty does in clinic, what happens to this patient. Usually, that's what the answer is for most of these things. What would be best for the patient, what's cost-effective, what's safe and standard of care choices. If you think about how you make the decisions in clinic, you'll usually be right. So here's one of my favorite ones. According to the AFFIRM and RACE trials, which one of the following is the correct statement regarding atrial fibrillation treatment? A, rate control leads to better survival outcomes. B, rhythm control leads to better survival outcomes. C, rate control is associated with better cardiovascular outcomes. D, rhythm control is associated with better cardiovascular outcomes. E, rate and rhythm control have similar rates of thromboembolic events. And so cardiologists like talking all these acronyms. Is like even at parties they're still talking about these trials. Well, did you see this and did you see that? So when I read this, I go, the who and the what trial? It's like, I don't know. Maybe I've heard of them, but I don't think I know what they said. So how am I going to figure this out? It's like, okay, well, I know that all the cardiologists, they like live there. They like live and breathe this stuff. So then I figure out, well, what happens to the patients that I send to cardiologists? Because it must be based on the RACE and the AFFIRM trials if those are based on that. So does everybody I send to cardiology just get rate control? No. Does everybody just get rhythm control? Like, no. Does everybody, if they have their rate controlled alone, is that better for cardiovascular outcomes? I don't think so. Is it rhythm control that's better cardiovascular outcomes? It's like, no. It's like, so sometimes they convert them, and sometimes they just give them rate control. So they must be fairly equivalent. So rate and rhythm control give you essentially the same outcomes. And so I got the result of the AFFIRM and the RACE trial by looking at what my smartest partners and what my referring consultants are doing, even though I don't know that. So just use the data you have from practicing medicine to figure out what the answers are. So think what your cardiologists, your smartest partners are doing. Do they send them for repeated conversion or ablation procedures, or do they do rate control and anticoagulate most of them? They do the latter for most of them. So frame of mind, you have to sort of reframe how you think of these things. Exam day and prep, get a good night's rest. Easy to say, hard to do. Protein breakfast is good because if you eat just carbs, you'll raise your sugar up, then you'll spike your insulin, then you'll get hypoglycemic. You get hypoglycemic, you don't function as well. So eggs, juice, maybe some yogurt, not too much caffeine, not super sugary juice. If you usually take caffeine because if you don't, you will get caffeine withdrawal headaches. Dress comfortably, arrive 30 minutes before appointment time because things always get screwed up. Use the bathroom before testing. You can take breaks when you're given the opportunity, but sometimes it's a block of time and it counts against your time. And so it'd be better off to not spend your time doing that. Don't eat too much or too little, especially don't carb load at lunch unless you're going to run a marathon instead of come back and take the second half of the exam, because carb loading will make you sleepy. So mind the distractors. I told you about this. Is like you go through the distractors are all the wrong answers, and it's what test item writers spend most of their time thinking of. So the wrong answers, you want to look each of those up and find out what they do. So I gave you the example of the most typical cause of peripheral neuropathy is diabetes, but I want to know about the rest of these things. So B6, what does it do? It causes a pure sensory neuropathy. What does metronidazole do? It causes an anti-abuse effect, and it can cause a peripheral neuropathy. Cephalosporins, what are the side effects of that? They have 4 to 10% cross-allergenicity with penicillins, but they can also cause an interstitial nephritis. What do you need to know about Wilson's disease? Kaiser-Fleischer-Ring, liver problems, and dementia. Copper toxicity. Next year's version might be which of these causes peripheral neuropathy. So last year's version was which of these is the most common cause. But then if I've mined the distractor, I have a map of the territory, and I know that they might ask a peripheral neuropathy question, and that's one of the things that they consider valid knowledge. So internal cueing, opposites of one or the other are often true, like right versus left or left versus right. Unless they're equal, then it would just be a trick. Longer and more precise answer, most often correct. More choices of a single drug at different doses, often one of those will be correct. Choice of facts, true. So A plus B, A plus C, B plus C, B plus D, just D. More likely to be one of the first 4 and not a single one, because they wouldn't have combinations in there. So these are all of the things that give you like an extra 1 or 2% advantage, and I will always take something that'll give me a 1 or 2% advantage. External cueing, one question gives the answer to another. The board has several versions of questions on a particular item, and they sort of assign them randomly. So you might get 3 questions on hypothyroidism, and one of them might give you the answer to the other 2. So if someone gives you a gift, say thank you. They may randomize you 2 or 3 on the same subject. The stem of one may give you the answer to another. If you think this is the case, use your whiteboard to write out the data or question numbers and mark them and go back and forth. So you're not allowed to take permanent notes, but usually you get like a marker and a whiteboard. So you can go back and forth between those questions and look at them. Test anxiety, 2 folks, Ramirez and Bayak, did a test with fearful students, and they found out that they did better if they jotted down their worries. If you write about your worries for 10 minutes, it allows your brain to sort of put them off to the side and like, okay, those are taken care of, rather than they go around and around in your brain all the time and cause anxiety. So I call that go from choking to smoking. If you write down your test-related worries before you take a major exam, it dislodges concerns and clears the way for higher achievement. Now this we're going to talk about a little bit. This is Daniel Kahneman's work called Thinking Fast and Thinking Slow. He was actually given a Nobel Prize for this. So he talks about two systems that the brain has. They're not anatomically distinct systems. They're not firing networks. They're just two modes the brain has. System one is what the brain wants to be in, what it defaults to. It operates automatically and quickly and has little voluntary control. So if you say, what's 2 + 2? 4. You recognize somebody who's hostile coming at you, you don't have to like sit around and think of that, because if you were in the group that had to sit around and think if somebody who was hostile was coming at you, your genes did not make it from generation to generation. So you can drive a car on an empty road, you recognize stereotypes. System two is the engaged thing. It allocates attention to effortful mental activities that demand it. Complex computations, choice and concentration, finding a person in a crowd, filling out tax forms, checking the validity of a complex argument, and walking faster than your norm. So here's a couple of Kahneman things. So a bat and a ball cost $1.10. The bat costs $1 more than the ball. How much does the ball cost? So the answer that comes to mind is 10 cents. The answer evoked intuitively and is appealing, but it is wrong. More than 50% of students at Harvard, Princeton, and MIT gave the wrong answer. So these are pretty smart folks. Either that or they're well connected. But we're talking about the smart ones here. So it's safe to assume that those who gave the correct answer also had the initial intuitive incorrect answer and managed to resist that intuition. So if you do the formula, you say x plus y equals $1.10, x minus y equals $1, so then 2x is 2.10, so x is $1.05, then y, $1.05 minus y is $1, so y is 5 cents. So system one is involved, the conclusion comes first and the argument follows. So the things you want to do during your exam is you want to be able to turn on system two and think about things rather than just answer reflexively. So if it takes 5 machines 5 minutes to make 5 widgets, how long would it take 100 machines to make 100 widgets? 100 minutes or 5 minutes? It would take 5 minutes. If a lake, there's a patch of lily pads. Every day the patch doubles in size. If it takes 48 hours for the patch to cover the lake, how long would it take for the patch to cover half of the lake? 48 days. It would take 47. It would take 47 days because the last day it doubles in size, and so it would cover the lake. It would cover the half the lake in 47 days, and then the next day it would double to 48. So 40 Princeton students did the 2 questions above. If the font was washed out, fuzzy, or hard to read, 90% of them got it correct because they had to think, they had to concentrate, they had to get out of their normal mode. If the font was clear, crisp, and easy, 35% of them got them both wrong. So effort engages system two, and system one is often the default. Your brain wants to use less oxygen, less glucose. It wants to save and just go to that resting mode. So your brain would like to sit on the couch even if your body wants to be out walking around. If system one is involved, the conclusion comes first. The application of system two requires effort and some distress being engaged. System two in on mode is more alert, more intellectually active, and less satisfied with superficially attractive answers. It's more skeptical about just intuitive responses, and that's how you smell, taste, feel the right answers rather than just answer what they're trying to get suckered into. So most people speak at 135 to 175 words a minute, but the mind is capable of processing 400 to 500 words a minute. That's why I talk fast, also because I'm from the East. But if you, the time gradient between the rate people speak and the way they process allows for distraction of the listener. Conscious effort is required to stay at a slower speed and impairs processing. Higher speeds, or slower speeds, require focus and improve comprehension and processing. So anything that's outside the normal range makes you process it in a different way. That's true if you have an accent. It's true if you're bubbling underwater. That's me doing Tai Chi on the Great Wall of China. So we're going to end section 1.